Good afternoon, everybody, and thank you for joining this session today. I've met several of you, the attendees this morning, and I've been so impressed with your level of thinking, the types of questions that you're asking about the technologies that we're looking at. So this feels like a great time for physiotherapy and a great time for our incoming generation of physiotherapists as well. My name's Rachel Young. I'm a physiotherapist and have been since 1992, and I've always had an interest in neurological rehabilitation. Back in the 90s, exercise interventions for that patient group were often avoided. There was a belief that by exercising people with a neurological condition in terms of their aerobic condition or muscular strengthening, we might actually worsen their symptoms. However, in the noughties, we saw a lot of research coming out showing the benefits of exercise for people living with neurological impairment, but it's not without its challenges. So if you're living with sensory impairment, motor impairment, trying to navigate a conventional gym, trying to use something like a treadmill, trying to get on and off a static bike is really challenging. And that's where my interest in motorised exercise started. So if we can develop equipment that gives people a helping hand to move, then that will really help in terms of initiating movement, sustaining movement, so that people living with neurological impairment can improve their cardiorespiratory fitness, can improve their muscular strength as well. So my background is mainly around power-assisted technologies. I'll see whether we've got any slides coming up yet. In a minute, thank you. So I'm employed at Sheffield Hallam University and I work in a multidisciplinary research centre called the Advanced Wellbeing Research Centre, where we have engineers, exercise scientists, physiotherapists, other AHPs and clinicians all under one roof. We can share ideas, co-develop technologies and evaluate them. And what's really important is also community engagement and making sure that we've got really good connectivity with local clinical services and most importantly the patients and service users who access them as well. So the project that I'm going to particularly talk about today is around exoskeletons. So we've just completed a trial which explored the use of an exoskeleton for people living with moderate to severe multiple sclerosis. So exoskeletons, they have been around for about 20 years, but there isn't huge adoption of them in clinical practice. And I think talking to some of the attendees this morning, that's confirmed that several of the students have talked about going on to neurological placements, but no one, as far as I'm aware, had actually used an exoskeleton out in practice. And the reasons for that include the fact that they can be difficult to don and doff, and they are expensive as well. So exoskeletons, they can be categorised in various different ways, but I like to think of them in terms of the amount of motor assistance that the exoskeletons offer. So there's different types of exoskeletons which are available, and some of them provide full assistance of walking, so they can potentially be used by people with a severe or a complete spinal cord injury, with very little or absent movement to the lower limbs, and give those individuals the experience of walking. So those devices will include a hinged component at the hip and knee. They'll also include a stirrup for the foot as well. So it's taking care of all of those components which are a part of gait. They often have a backpack as well, and that's where the battery and the controller unit will be housed. So they're incredibly sophisticated pieces of equipment, but they are expensive and they can also take quite a long time to don and doff, and particularly if you're using them across different users. So it's really important, for example, that you've got the prosthesis length right, so it matches the length of someone's femur and someone's tibia. So the setup time can be considerable and you can need to experienced physiotherapists to set that up. The device that we used was partially assisted, so it's the Kyogo device, and it's actually on site, so we've got one available this afternoon if people want to come and have a look at it. And that's motorised from the knee joint, so it actually helps people to keep the knee straight during stance phase and then achieve flexion during swing phase. So at a minimum, users of the Kyogo do need to be able to transfer their weight at the hips. So they need to be able to weight shift as if they're about to initiate a step. But we certainly had people on our trial who had very limited mobility, were limited to just transferring and taking a couple of steps, quite often very dependent on walking aids to achieve that. And whilst wearing the device, they were actually able to walk a good 10, 20 metres before needing a rest. So that was a great experience for them, and really helped us to understand the benefits of this particular device. And it was much quicker to don and off as well. It wasn't as complicated in terms of the different components. Finally, there's also some inflatable exoskeletons. So these are the most affordable, most simple to use. They don't actually assist movement from a motor point of view, but they splint the limbs, so they help people to keep upright against gravity, and give really strong proprioceptive feedback as well. So I've got pictures of examples of these devices, which when we do have the slides, I'll be able to possibly pop back to that slide. So as mentioned, there's been a few barriers to adoption of exoskeletons in practice, and that does include the price, it includes the setup time and the expertise needed of the workforce to support users to do that, and particularly if you're in a clinical setting where you might want to use an exoskeleton with several patients across one day, it would mean there'd be a lot of time spent adjusting the limb length, for example, to make sure that it's suitable. Your first patient might be 5'4" tall, the next patient might be 6 foot, so you're going to be fiddling around with your Allen keys to address that. So that's one of the barriers to adoption. There's minor risks associated with it as well. So there have been reports of skin lesions and falls associated with exoskeleton use. So risk assessment, good attention to risk and risk management is also important. But the positives do include a growing evidence base which show that exoskeletons have both quantitative and qualitative benefits associated with their use. So for different clinical populations, particularly neurological populations, they are associated with improved mobility, improved fitness, and improved quality of life and mood as well. So thinking about our trial, I'll just give a few words about the research design. So it was a feasibility study. So the main question that we were asking, is this study actually possible to do? And what we wanted to do was to look at robot-assisted or exoskeleton-assisted gait training for people living with moderate to severe multiple sclerosis, and to compare that to a conventional exercise intervention. So this piece of research was sponsored and funded by the MS Society, and we worked with Sheffield Teaching Hospitals and the University of Sheffield to deliver the intervention. There were no conflicts of interest associated with the research and the research team. So we recruited 24 people living with moderate to severe multiple sclerosis. So we looked at the extended disability status scale and indicated that people with a score of between 5 and 7.5 would be eligible to join the study. So at a score of 5, we're looking at people who are able to walk approximately 100 metres. With a score of 7.5, that's for individuals who are able to transfer but not walk for any longer distance. So it's quite a big spectrum of participants who joined the study. We found that of the 12 people randomised to the exoskeleton arm of the trial, unfortunately, 4 were unable to join the trial following consent due to complications such as a relapse with their condition, or in one case someone was moving house, so it just wasn't good timing. However, of the 8 people who made it from consent to their screening session, everybody completed the trial, and that's unusual. Usually with an exercise intervention, you'll find some people do drop out over the course of the intervention delivery. So we delivered the intervention over 8 weeks, 2 sessions per week. We had really high attendance rates, and one of the secondary outcome measures was looking at cardiorespiratory responses as well. So the target heart rate in each session was 70% of each person's age-predicted maximum heart rate. So that was the intensity which we aimed for during the walking sessions. And we found that was mostly achieved. So we had no dropouts, really high attendance rates, and we were able to achieve the intensity of exercise that had been stipulated within the protocol. We did have a wide spectrum of abilities who joined the project. So, for example, some people who were able to walk a good 100 metres outside, but would then become fatigued, experience movement inefficiencies. So, for example, the video that's running next door, the participant there tended to start catching his left foot after walking between 50 and 100 metres. So people were able to walk much further and more quickly with the exoskeleton on. And it increased as the weeks went by as well. So, for example, in the first few sessions, they might only have achieved 50 metres or 100 metres of walking, but that distance gradually increased over the course of the sessions. So we're just analysing the data now, but the key question around, is this a feasible study design? The answer to that is yes. Equally, we had people who had a successful intervention with conventional exercise as well. So I think there's more questions to ask in this space, and we're going to use the experiences from this trial to develop a protocol for a larger powered study to understand more about how we support people living with moderate to severe MS to engage in exercise and achieve aerobic benefits. So my closing words to you as a physio who sits on a multidisciplinary table with maybe an engineer here, a robotics expert here, a software developer here, is absolutely get your elbows out and get around that table, because it's so important that our clinical perspective and the way in which we can represent patients is reflected in the development of these technologies. And embrace any opportunities that you have to be involved in any co-design exercises or testing studies to look at new technologies. And be honest, if someone's got an idea that needs refinement, then share that point as well. Thank you for listening. And come next door, because we've got the video running there.
The good thing about physiotechnologists is that they can innovate and do things a little bit differently and slightly off the cuff. So Rachel, thank you. We are just about able to get the slides up. For everybody here, though, with Rachel's permission, we would hope to share the slides with you all so you don't miss out on what Rachel was speaking about in slide version. But again, have a look next door. And hopefully, not hopefully, we might get the slides for Brooke and for Claudia. Again, if not, that you're going to see it on screen, then you will definitely get them sent out to you after the event. It doesn't look like we're going to do it. Brooke, slightly off the cuff, are you happy to go without slides for now, and then we'll keep going with, see if we can fix it.
Hello, everyone. My name is Brooke Nairn. I am a physiotherapist, as well as a research assistant, and I'm also completing my PhD on the project that I'm going to discuss, based out of UCL in London. So the project that I'm working on, and that I have a display, some of you I think have tried out, is called Telerehab Decision Support System. And so I'm going to emphasize how this AI and augmented reality system can be an excellent adjunct for physiotherapists. And I think, as Ewan had mentioned, this is a key piece to the digital transformation of physiotherapy, is to look at it as an adjunct, just like you have your MOBs, your soft tissue work, your exercise prescription, and we have our digital innovations that can also assist. So the Telerehab project, it's a Horizon Europe funded project, and we have 15 partners globally. So it's a really large project, which is brilliant because we interact and we are looking at delivering the system in different geographical boundaries. We have partners developing the technical platforms. Yay! Yay! There we go. So maybe if we skip to the next slide. I can do that. So this is what I was discussing. It's a very cross-boundary project. We have 5 clinical sites. So at London, we are the lead site, a site in Thailand, Madeira, Greece, and Germany. And we will be delivering the study. I'll get into the details of it, but with 500 participants. And then we have various technical platforms or partners, because I am by no means doing all of that. So why is this work needed? Well, we have a falls epidemic, as many of you may already be aware of, in the aging population. And this accounts for most emergency department attendees in the older population. And of course, this has a heavy economic burden on the healthcare system. We know this, and we also know that balanced exercise that is multifactorial and is individualized has a huge impact on reducing the risk of falls. So yeah, we know this information, but current programs are suboptimal. There's a lot of just traditional standard programs that are used, and they're not always multisensory, and they're not always including cognitive components, which are key pieces, especially in an older population, that is needed to look at reducing the risk of falls, and this leads to a high dropout rate. So despite this, we also have limited access to specialist service, limited specially trained vestibular and or balance physiotherapists, and so this is what this project is addressing. So yeah, this is the trial that I was mentioning. 20 months, about 500 participants, 5 clinical sites, and it will be a 12-week intervention, 5 days a week. So it's quite full on. They will have the system at home. It's performed in the comfort of their own environment. And we are looking at using the system within stroke participants, individuals with mild cognitive impairment, vestibular inner ear dysfunctions, and dizziness following long COVID-19. So individuals at risk of falls. And the overall ambition is that we want to provide optimized and semi-automated, which is where the AI component comes in, telerehabilitation that is both affordable, which I'll touch on later, treatment for patients at risk of falls with remote, balance, physiotherapy, ultimately looking at reducing the risk of falls and their comorbidities. So how are we going to do this? So an AI decision support system is being developed to streamline the entire clinical pipeline for management of these individuals. And this starts from the AI decision support system aiding in which intervention strand this patient will perform best in, the reps, sets, exercises they will perform best in based on the real-time feedback it collects. It will provide projection outcomes, predict adverse events. And this is a quick schematic of the equipment that will be included. So as I have on the table as well next door, there's a head-mounted display, 4 inertial measurement units for body motion tracking, as well as a depth camera for even further data collection, heart rate monitor, and wrist strap. So we're collecting a lot of information. And yeah, as I mentioned, it'll assist with intervention planning, prognostic factors for treatment effectiveness. This button doesn't like me. There we go. Automated remote patient monitoring and real-time feedback that you as a physiotherapist, you'll have a dashboard, patients performing this at home, and you're going to objectively see all of this data that, it's a lot more information that you necessarily see by the human eye, say in clinic. And so, you know, if there's a risk, they're leaning outside their limits of stabilities, perhaps they're at risk of falls, you can contact them and you can see their sway parameters, how many exercises they're completing, how much of the reps and sets they're completing. So, this is a busy slide. I'm just going to hit the key points of the project. So there's a clinician dashboard, which I just mentioned. There's a patient mobile app. We have the AI decision support system, and then we have the continuous exercise monitoring, and these all work together. So this is a diagram, and this has been developed by our partners Uninova in Greece. It's customizable. We've done a lot of user groups and focus groups with clinicians to make sure that it matches the workflow of what they want to see, in what order they want to collect various information, and this is where all the clinical assessment data will go. And this is what they will, the physiotherapists will have in clinic or wherever they are. The mobile app, similarly, we've done focus groups with patients so that we've customized this according to their needs. So this is going to help with motivation, self-management, adherence. They're going to be able to complete questionnaires at various time points. They will have their exercise calendar, and they'll be able to contact the team if anything comes up. Yeah, their activity monitoring, just like many of you probably have a Garmin or some sort of smartwatch, you can see that data. And then the e-health literacy, which is also a really key piece, especially in the older population. So We've developed an assessment that the participants will perform before the study to get an idea of how adept they are with various technologies, and we will have a high and a low-tech solution in the study. And then what we're going to look at afterwards is, did individuals that say had low e-health literacy, did that improve with the higher the low-tech system, or did it maybe decrease? Was it overwhelming? So this is questions that we want to look at, and then we're hoping that we can validate this tool to be used in future research so that in other studies and in other practice, it's a good tool for evaluating individuals' e-health literacy. We'll get there eventually. Oh, sorry, let me go back. So these very basic things that we would all perform: typing, hitting a few buttons, making a selection, so just to get an idea of their basic knowledge with technology. And then this is the bread and butter of the program. So the rehab program is going to have multi-sensory balance exercises. There's going to be a holographic physiotherapist displayed. There'll be exergames, cognitive training, and of course the remote objective data that the physiotherapist will receive. And this is augmented, so you still see your environment, and this is a really key piece for safety. And there's an overlay of a hologram on top, and you can check that out at the stage in the next room. And for example, the seal, this has been designed by our team. So this is an exercise where they have to balance to keep the ball on the seal's head. So it's just to make it a bit more interactive, because sometimes exercise can be boring and we want to improve engagement and adherence. I'm going to skip that for the sake of time, but it is on YouTube. So I'll just briefly go through this. What do we want to do with all of this research? What do we hope to achieve? From a clinician's perspective, I hope you can all see that this can really be a fantastic aid in assisting with the intervention assignment, reps, sets, exercise progression, and better predicting patient outcomes and adverse effects. From a patient's perspective, huge assist in reducing travel time and costs. I know at a center that we work at in the clinic in London, we have patients coming from all over. And this is really difficult for individuals with balance, dizziness, vertigo symptoms. And so, of course, reduced travel time and costs, hopefully improved outcomes, improved quality of life. And this comes back to the affordability piece at the healthcare system level. So another key piece of the system is that we're going to be able to allocate based on resources at various health centers that they have available, staff costs and time, so that we have a more feasible use of these resources, hopefully, obviously, reducing the risk of falls, which has a significant impact on the economic burden. And then at a policy level, we want to implement guidelines and policy changes to better implement these digital innovations and look at how this big data analytics and this objective data can be a terrific aid in the physiotherapy workforce. So I'll just finish up by saying that, yeah, as a summary, Telerehab DSS aims to produce the first predictive model for individualized decision-making for patients with balance disorders at risk of falls. And we want to address the question of what treatment is optimal for both compliance of the program, effectiveness, and of course, this is all on an individualized basis. So that is it for me. Yeah, and just a huge thank you. I'm a really small piece of this project that has just had the opportunity to present it, but as you can see, something like this takes a lot of different partners and a lot of engagement from, various partners. So I just want to thank everyone else, and thank you for listening. Any questions after?
So thanks, Brooke. And last but by no means least, speaker for this session is Claudia, who hopefully will have slides and a working clicker.
That'd be good. When at the end, or no? Can we start the slides again, please? That's not the right one, though.
You let everybody know who you are and I'll fix the slides.
Hello, everyone. My name is Claudia Lindner, and I'm a Senior Research Fellow and Early Day Fellow at the University of Manchester. I have to admit, my background is not in physiotherapy. My background is in computer science, but I've been working in medical image computing for the last 15 years or so. So I do a lot of work working on medical image with a particular interest in musculoskeletal diseases. And so we are developing tools to automatically extract information from medical images, and then we use that information to link to various conditions. So it could be, for example, to diagnose a disease early. It could be to help clinicians to assess the severity of a disease, to maybe monitor progression of disease, to monitor progression in response to treatment. We also do some population-based studies where we actually use that information from the images and link it, for example, to genetics data. And so this is to identify on whether we can find any underlying genetic predispositions, for example, for someone to have a certain condition or to progressing quickly. But today, I'm here to talk to you about enhancing musculoskeletal care with AI from concept to clinical application. 1.7 billion. Now, this is the number on how many people across the world suffer from musculoskeletal conditions. And so that includes conditions such as osteoarthritis and osteoporosis. And also, musculoskeletal conditions are the leading contributor to disability worldwide. And for us, that's the motivation why we are working in this space, because there's a significant impact on these patients. And that led us to looking into bones. So we particularly are focusing on extracting information about bones or kind of bones from medical images, because that allows us to study and diagnose disease, but also to plan and monitor treatment. And so today I'm going to talk to you about some of the technologies that we are developing in that space in the research setting, and then I'm also going to comment on some of the factors to consider when taking such a technology from a research setting into clinical application. And so one of the core technologies that we've been developing to extract information from the images is what's called the bone finder technology. And that is basically all about locating points. So in an example that we'll see in a minute, the system will go away and will outline the left hip bone with 65 points. And so it's a machine learning based approach, or AI if you want to call it that. And so it's based on training data where we define what structure are we interested in and what part of that structure do we want to outline, and then we train that system. And so the system learns about what to look for in the image, and it learns two basic aspects. One is, where roughly is that object in the image that I'm looking for? So you could imagine that you've got an image with two knees, but you're just looking for one knee. You could imagine an image that is slightly rotated. So it's about really kind of nailing down where is the knee in that image. And then the second bit is where we take the much more detailed look, where each of our individual points goes away and tries to identify where they should be positioned. Now, to make that a bit more tangible, I'm going to give you 3 different examples on how we're using that technology to address different clinical needs. Now, the first one is this one, and this is on automatically assessing hip migration in children with cerebral palsy. So in children with cerebral palsy, they've got a really high risk that their hips will dislocate because they've got these abnormal massive forces, keeping forces on the hip bone trying to pull it out. And so that needs to be monitored. And so these patients get regular X-ray images, and one of the key measurements that needs to be taken from those images is what's called Reimer's migration percentage, which is used to assess on how far the hip bone is still in the socket or might have moved out. And currently in practice, it's a manual process for the doctors to take that measurements, which means that in areas where there's a lack of capacity, it doesn't always happen, or it happens with several months of delays. And this is where we're coming in and saying, oh, hold on, we can do that automatically. And so we've come up with a bone finder model to outline the relevant structures of the hip X-rays of those children. And then we use those points to automatically calculate the Reimer's migration percentage. And so we validated that technology on a large clinical data set of 650 children with cerebral palsy. And the way we assess the performance is by we compared our automatic measurement to that of 5 clinical experts who have also measured the very same images manually. And what we found in performance is that there was excellent agreement both within the 5 clinicians that took the manual measurements, but equally good agreement between the manual measurements and our automatic system. And actually, when we looked at the mean difference between the automatic system and the manual measurements, we found that that was in the range of what would be expected if we were to ask a clinician to measure the same image twice. And so we can say that our system performs equally well in automatically generating these measurements, providing huge opportunities to improving the pathway for these patients. The second example is on a condition called charcot foot, which is a risk for patients with diabetes. And unfortunately, this is a really destructive disease, which leads to bone fractures and can lead to foot collapse. And when it gets to that stage, those patients will have a really high risk of developing ulcers, but also of amputations. And so the key here is to identify early who is going to develop a charcot foot. Now, at an early stage, it's very difficult to spot. So there's two images here, which are what we call normal looking, because if you present them to a clinician, they couldn't tell you which of them is going to be fine and which of them is actually really, really close to having a severe charcot foot. And so we've collected a data set of 95 normal looking images. 55 of these have no disease, but the other 40 actually went on to develop charcot foot, so they were in the very early stages. And so again, we've developed a bone finder model to outline relevant structures of those lateral foot images, and then we used the point position that we captured to describe the shape, but also the texture information of the foot. And we identified certain patterns that actually are in the image, which are allowing us to identify early which are the patients that we need to follow up close and which are the feet that we might have to put in a cast to avoid the destruction of the feet going forward. Now, the last example is this one, which is on automatically assessing knee alignment. And so here we're working on standard AP knee radiographs. And again, we've developed a bone finder model to outline the structures of the knee with the goal to automatically deriving measurements which are relevant to assess knee alignment. And so one example is the anatomical tibio-femoral angle. And so that then gives us information preoperatively, but also postoperatively for patients who have knee replacement surgery. And we also can link that information going forward to, for example, pain scores, function scores, or other patient outcomes. And so this was just a really quick run through some of the applications that we are developing in this space. And now I'd just like to give some insights on the different aspects to consider of taking such a technology into the clinic. And so working in that space, it's a huge program of work of taking something that's been developed in a research environment to something that is being used in practical application. And we won't have time today to go through all the different steps, so I just thought I'd pick out 3 to comment on. The first one is market discovery. And that one really is all about identifying the opportunity for the innovation. So it's about identifying the real need, so making sure you're actually addressing a real problem. Potential users, who are the people who are going to use it? Is there sustainability? Is there a market for actually developing and acquiring and using that technology? And that links very closely to the second one, which is co-creation, also called co-design, co-development. And this is really about getting different groups of people, different stakeholders all together. So for us, from a technical background, this is really important to work with you guys and any clinical profession that is involved in the type of diseases that we are working with, because that's where we get the input in terms of what are the problems on the ground, what might be helpful, what might not be helpful, how could our technology be useful, how could make it your life easier and the patient's outcomes better. And the last point to mention is generalizability. And generalizability here means from a technology point of view, to have a technology that can be applied across a diverse group of people. So that does not just work for females, or just works for children, or just works for a hospital in the north of England, but that works across the population, across different diseases, across different image types. And particularly in the space of AI, I think this is really, really important. And I'm going to give you just an example on how this applies in medical imaging research. So people who are developing medical imaging technologies quite often use this kind of data. So these are cohort data sets. So it means all the images look nice. So they kind of all look the same. They have different patients, but they're all standardized in a nice setting. Well, if you go into the clinic, the images look like this. So there's so much more variation. There's not just more variation across different patients, but there's also more variation even within the same patient at different time points. It might be different imaging protocols, a different radiographer would apply slightly different style, a different machine that is used to acquire the X-rays. So there's a whole range of variation. Now, the reason why a lot of the technologies are developed on the cohort data set is because they're easily available. And as you may know, for AI technologies, you need training data, you need a lot of data. So easily available data is the place to go to. Whereas clinical data can be quite challenging and also very time-consuming to obtain that. So you can see the clear barrier on why it's not being done. However, if one is to develop something that they want to use in clinical practice, you do need to use the clinical data, because otherwise it's just going to fail. And I think it's just something to be aware of when one is working in that space of developing technologies for clinical application. But it's also a bit of a, I guess, almost a warning for potential users of AI systems to be aware of what was actually used to develop, but also to validate that the system works well, and to question what are the limitations of the system. So just because it's working for this group of people doesn't necessarily mean it also works for the other group of people. Now, in conclusion, I think there's a huge opportunity for using AI technologies in that space for a whole range of applications and to improve, for example, diagnostic accuracy. If one was looking into develop something that is going to be taken into the clinics, I think it's really, really important to consider translational factors right from the outside to get an idea on what is the clinical environment, what is the IT infrastructure, and everything around, and equally to involve a whole range of stakeholders to really understand what is it that is needed, how can we develop something that fits the gap and that is actually going to be useful in the end. And I think if we take all that into account, there's a huge opportunity to improve the outcome for our patients. Thank you.